Hi, so I'm going to talk to you today about the role of imaging in regional lymph node staging in breast cancer. So with all of the trials that have been discussed in this presentation and recently in literature, the question is, do we need to image the regional lymph nodes? So the outline for this talk is I'm going to talk about the sensitivity and specificity of regional node staging using imaging, and then talk about when is imaging indicated. So ultrasound for imaging the regional lymph nodes. This is indicated, in my opinion, if there are clinically palpable nodes or greater than T2 disease, and this is based on the results of the Z11 trial that was already discussed. Imaging signs of disease are cortical thickening, hilar displacement or compression, loss of a normal hyla, and then the shape changing or margins. So here are some pictures. I don't know if there's a pointer. And the mouse here. Okay, there you go. This is a normal lymph node with a normal fatty hyla, and this is hilar blood flow, which is normal. The bright here is fat, and the dark is the normal cortical hyla. Here again is a normal lymph node. This is a normal cortical part of the lymph node, and here is the fat. So here is an abnormal lymph node on imaging. Instead of just having the hilar blood flow, there's increased vascularity. The normal fatty hyla, which is this echogenic portion, is completely displaced or absent, and this lymph node is actually also enlarged. And just another example, this is a normal lymph node on ultrasound. This is fat centrally. This is the cortex. The threshold here is 3 millimeters, so if this cortex right here is greater than 3 millimeters, that's considered enlarged. Here again, echogenic, normal fat, normal cortex. Abnormal lymph node, this shape is abnormal, the lymph node's enlarged. This cortex is certainly more than 3 millimeters. And here again is an example of an abnormal lymph node, increased cortical thickness. So how good are we at staging? So axillary lymph node fine needle aspiration has a fairly good sensitivity and specificity for a positive lymph node. PPV of 100% if it's positive, although there can be some false negative cases, especially with small metastatic deposits, and that's because in a lymph node that's involved with metastatic disease, it may not be the entire portion of the lymph node that's involved. It may only be a small portion, and so if you're only putting that needle in a very tiny part of it, you can miss metastases. Now, an axillary core does a lot better at picking up metastatic disease, but then there's risk of injury to adjacent structures, and there's a risk of bleeding with this procedure. So generally, if there's a good cytopathologist, we do axillary FNA, realizing that a sentinel lymph node biopsy is more sensitive for disease than ultrasound-guided. So what about extra-axillary lymph nodes? In one study looking at T3-4 disease, N2, N3 disease, there was unknown extra-axillary metastases in the infraclavicular region in about a third of patients, supraclavicular 16%, and internal mammary 11%. And remember that number for internal mammary, the pink star means that is a SAM question. So that's kind of an indication to remember that. So 10% unsuspected internal mammary disease. So going on to MRI. Now we don't really use MRI to stage regional lymph nodes. An MRI is sometimes done prior to surgery to look for ipsilateral or contralateral disease. This is still controversial in the field. There's about a 3% yield of unknown contralateral disease in all-comer patients who have a newly diagnosed breast cancer. And there can be, depending on the patient population, in our population, about a 14% incidence of additional ipsilateral foci that are greater than 2 centimeters away from the index cancer in all comers. This is why MRI is done pre-surgically, and that it is still controversial whether all patients need this or which patient population needs this, but that's a different talk. So on MRI, though, sometimes we will notice that the axillary lymph nodes are big. We may notice internal mammary lymph nodes are big. Signs of disease, same as with the ultrasound, cortical thickening, loss of normal fat, a change in shape, spiculated margins. or matting of internal structures. And here's an MRI, and you can see these are normal lymph nodes. This lymph node has an increased cortical thickness. This is an abnormal lymph node on breast MRI. This would not have been performed to stage these lymph nodes, but this would be incidentally discovered. Again, here are the normal lymph nodes, and here are enlarged lymph nodes. Now, if you're looking at this talk, this is a little bit more, here's normal lymph nodes. Here are enlarged lymph nodes. So one thing you might be thinking, well, what should we do? So you did this MRI, you didn't do it to stage the regional lymph nodes. Now you find an enlarged regional lymph node. What's the right thing to do? Should we ignore it? Should we look by ultrasound and possibly biopsy it and have it be positive? And I think I'm going to talk later, I think it depends on the stage of the tumor. Let's just say that this woman had T1 disease and you did an MRI and you found an abnormal lymph node. Then if you decide to do an FNA and that's positive, what happens to that woman? Is she committed now to an axillary nodal dissection or not? If you say no, I still want her to qualify for Z11. I don't want to go ahead and do an axillary nodal dissection. Even if that lymph node is known positive because you did this MRI because this woman's clinically negative, then you shouldn't look by ultrasound and you shouldn't do the FNA. So I don't think that was probably hard to follow because you've heard a lot about Z11, but basically still, if the woman has a T1 or T2 tumor and we see enlarged lymph nodes on MRI, in general, our surgeons will not want us to pursue that. So here's another example. These are normal lymph nodes. This is an abnormal lymph node on MRI. Because we don't know what it means when we find these lymph nodes now and the woman is clinically negative in the axilla. So going there, MRI, this is another SAM question, sensitivity of 82% for a positive lymph node. Why isn't it 100%? Because lymph nodes can look morphologically and structurally normal and still have micrometastatic disease. So some people have looked into, well, MRI is pretty good for staging. Maybe we can get as good as a sentinel lymph node biopsy if we look at quantitative characteristics like diffusion-weighted imaging, which is something where we look at the diffusion of water in the tissues. And this study showed that quantitative features were not any better than structural MRI. And also different contrast agents really didn't increase the sensitivity. So far imaging cannot replace a sentinel lymph node biopsy. So this is another, this is spoken in a different way. The sensitivity of a standard protocol of MRI, this is a SAM question for breast and axilla for detection of axillary lymph node metastases, 82%. So going on to PET. PET is also done not just to stage the regional lymph nodes. The indication for PET is systemic staging in stage 3 or stage 4 disease, and stage 2B is optional. This is still an area where there is active research. So the signs of disease are the same, except that you also have this thing called the standardized uptake value. So PET has also a very good sensitivity, 82 to 86%, specificity of 92 to 97%, but a very high PPV of 98%. Reasons for false negative exams on PET are a small number of lymph nodes, but it's highly predictive when multiple intense regions are present. So the PPV of an abnormal axillary lymph node on PET is 98%, and that's a SAM pink star there. So you wouldn't need PET if this was your abnormal internal mammary lymph node. This is fairly obvious structurally on imaging. But here in this patient who doesn't have any obvious internal mammary abnormal nodes, the PET clearly showed that there was an abnormality. So 50 years of research has not shown, in my opinion, a significant clinical benefit to radiation just of that internal mammary lymph node chain if all comers are taken and staging isn't considered in the clinical trial. So far, no trials have used imaging to guide patient selection, so I would encourage that in future trials. And again, we've talked about this already, 10% of patients with locally advanced breast cancer will have a positive lymph node by PET-CT. So the percentage of patients that have an internal mammary lymph node detected by PET-CT if they have locally advanced cancer is 10%. So going on to the final part of the talk, when to image. In the radiologic literature, this fairly complex graph came out several years ago, looking at when we should image lymph nodes. In my opinion, they said, if there's palpable nodes, you should do an FNA. If it's negative, they'll go to a sentinel lymph node, which is more sensitive. If it's positive, they go on to axillary node dissection. If no palpable nodes, they wanted to go to ultrasound, see if it's suspicious. Maybe if you see it on mammography or if you see it on MRI, it's suspicious, you should go to ultrasound and then make a decision based on that. In my opinion, now with the advent of these trials, we should take off this part of the graph completely. And if it's a T1 or T2 breast cancer with no palpable nodes, we should not proceed to imaging. So there is a trial to see if there will be some relevance for imaging in axillary nodal staging and if a sentinel lymph node biopsy will be necessary. And this is looking at cancers less than 2 cm, so very early stage cancer. If there's an indeterminate node on ultrasound, they undergo FNA. If the FNA is negative or there's a negative ultrasound, these patients will be randomized to conventional management, which is the sentinel lymph node biopsy, or no axillary staging. And so ultrasound here might be used to avoid sentinel lymph node biopsy. In my opinion, this would take this exam, which is now irrelevant in T1, T2 patients, and make it relevant again if indeed this trial has positive results. So the risk of axillary metastases, as you know, increases with tumor size, with tumors at 5 cm having a 70% risk. So do we need to image the regional nodes? This is, in my opinion, the axillary ultrasound and FNA is only indicated if there are clinically palpable nodes or greater than T2 disease, which is greater than 5 cm. And systemic staging, including regional nodes, is indicated if the sentinel lymph node biopsy or clinical exam indicates greater than stage 2B disease or possibly stage 2B disease. So future directions, how can imaging help us? Quantitative imaging may eventually be used to predict treatment response or prognosis for regional nodes. Possibly in the future, imaging phenotype could predict who would benefit from sentinel lymph node, axillary dissection, axillary radiation, internal mammary radiation. We've discussed this, that's that current trial. We've discussed this, possibly using imaging for patient selection. And if an imaging phenotype is predictive, which one would that be? Would that be the phenotype of the primary tumor or the phenotype of the axillary nodes? As I discussed, the one trial looking at diffusion-weighted imaging here was not successful. So can imaging help to identify patients who do not need treatment? And I thank you for your attention.